Good morning, good afternoon, and good evening, philosophers, and welcome to video 9 of Philosophy of Science through the lens of medicine. Today we're shifting focus away from traditional philosophy of science and towards issues more specific to philosophy of medicine, in particular the debate between evidence-based medicine and patient-centered care. Imagine that you visit two doctors. Doctor 1 says, for people with your diagnosis, treatment A reduces the risk of a stroke by 30%. And Doctor 2 says, before we choose a treatment, what matters most to you? Which do you prefer? If your answer is both, congratulations, you're sort of anticipating the conclusion and saved yourself roughly 200 journal articles. So today we're looking at evidence-based medicine and how it compares with patient-centered care, what they are, and why we wanted them. The boxing match comes next. EBM, or evidence-based medicine, emerged as a named movement at McMaster University in the early 1920s. Its founders argued that intuition, unsystematic experience, and reasoning from bodily mechanisms should not, by themselves, settle clinical decisions. Very knowledgeable doctors could confidently recommend treatments that didn't work and remain confident for decades. I've done this for 30 years is evidence of experience, but it's not yet evidence that the treatment actually causes anyone to recover. David Sackett and his colleagues gave the classic definition. EBM is the contentious, explicit, and judicious use of current best evidence in decisions about individual patients. As clinical practice, it integrates the best available research with clinicians' expertise. So EBM is not published research replacing your doctor with a search bar. It makes the doctor's judgment answerable to systematic evidence. This brings us to the famous evidence hierarchy, usually drawn as a pyramid because academia can't resist turning a complicated idea into a triangle. For questions about whether a treatment does more good than harm, the simplified hierarchy looks like this. Near the top are systematic reviews, sometimes with meta-analyses, which combine several good studies. A well-conducted randomized controlled trial, or RCT, usually comes next. In an RCT, participants are randomly allocated to a treatment or comparison group to balance confounding factors. If everyone receiving the drug lived in Cape Town and everyone receiving the placebo lived in Johannesburg, we wouldn't know whether we had tested the drug, the altitude, or the psychological benefits of seeing Table Mountain. Random allocation helps isolate the treatment's effect. Below RCTs are observational studies. A cohort study might follow smokers and non-smokers and compare how many develop lung cancer. A case control study starts with people who have lung cancer and looks backwards for differences in exposures. Such designs help when experiments would be unethical, impractical, too slow, or concerned with rare harms. Then comes mechanistic evidence, clinical experience, and expert judgment. These are important. A surgeon facing an unexpected bleed can't pause the operation for a systematic review, but they're easier to misread, so classical EBM ranks them below comparative clinical studies for treatment effects. One qualification: there is no single hierarchy for every question. RCTs suit many treatment questions. Diagnoses, prognoses, and patient's experience require other designs. Sackett in EBM was not restricted to RCTs and meta-analyses. Best evidence means the best evidence for the question, not whichever study occupies the nicest floor on the pyramid. The motivation is to make medicine less dependent on authority, selective memory, and persuasive anecdotes, to estimate benefits and harms more reliably, and to give guidelines something sturdier than Professor Famous has always done it this way. So now let's move from the pyramid to the consulting room. Patient-centered care begins from a different concern. A patient is not merely a diagnosis with shoes on. Michael Balint helped introduce the language of patient-centered medicine in the 1960s. Judith Bensing later described a humanistic biopsychosocial approach attentive to the patient's worries, needs, preferences, and participation. Mead and Bauer emphasized the patient as a person, shared power and responsibility, and a therapeutic relationship between two people. In practice, Patient-centered care, or PCC, means listening to the patient's experience, understanding their context, explaining options and uncertainties, and making decisions with them rather than issuing instructions at them. This is shared decision-making. Suppose treatment A offers a small average increase in survival, but is likely to cause severe fatigue. Treatment B offers less of a chance of extending life, but makes it more likely that the patient can remain alert, work, travel, or, care for a child, anything that they value, really. Evidence can estimate those probabilities. It can't determine which trade-off is worth making. That depends on what the patient values. Patients know things a blood test can't reveal, like how the pain feels, what side effects they can tolerate, whether they can afford weekly travel, and which outcomes make treatment worthwhile. They're not medically omniscient, but they attend every minute of their own life. PCC is also not identical to personalized or precision medicine. A treatment can be exquisitely tailored to someone's genome while completely ignoring what that person wants. Its motivation is ethical, practical, and epistemic. Respect autonomy and use the patient's knowledge of their circumstances, goals, and lived experience. So, 2 centers of gravity, not 2 caricatures. EBM begins, what does the best research show and how should it apply to this patient? PCC begins, what matters to this patient and what evidence can help achieve it? Those are different centers of gravity, but we shouldn't manufacture a disagreement by caricaturing either side. Sackett's EBM explicitly includes clinical expertise and the patient's predicaments, rights, preferences, and choices. External evidence informs clinical judgment, it doesn't replace it. Properly understood, EBM is not cookbook medicine. And PCC doesn't make evidence optional, require every requested treatment, or make antibiotics effective when chosen by sufficient enthusiasm. A patient-centered clinician still explains the likely benefits, harms, and uncertainties. Clinician and patient then deliberate together. Evidence gives us a map of the likely consequences. Patient values determine which destination is worth reaching. So, why is there a debate? Because the approaches can still disagree about whose knowledge counts, how population averages apply to unusual individuals, where professional judgment ends and patient authority begins, and what to do when evidence and patient priorities pull apart. That is the fight for the next video. Thanks for watching, please like and subscribe, and I'll see you on the next one.